Hey everybody, so my name is Stuart Schlossman and this is a new program that we're doing today called Making MS Boring. All right, I'm in our studio in Longwood, Florida. This is the studio of Orlando Production. I wanted you all to know about this. We're in 5,000 square feet of space. My video producer is approximately 30 feet away from me right now, so it does make it easy for me to take off my mask and not have to worry about anything, all right? All right, again, this is as you can see, ways to make MS boring, all right? And our virtual sponsor or virtual exhibitor for today's event is Genentech. And I want everybody to be thankful that they're supporting us to do today's program. I am very thankful and I want to let them know that as well. All right, today we're going to do something different. First off, you all know that Dr. Boster is on, all right? You're going to see his face in a few minutes, all right? But he's going to speak for about 35 minutes. There he is, right on and off real quick. All right, he's going to speak for about 35 minutes, and he's going to do an hour's worth of Q&A. All right, an hour's worth, all right? And we have a lot of questions that we took from people as they were registering. By the way, over 200 people are registered for today's event, and I want to thank you all for being here as well. All right, before Dr. Boster, this program was originally supposed to be happening in Roanoke, Virginia today, but because of many various reasons, including that the people of Virginia did not want people from Florida being there because of all of our variant status that's going on in Florida. All right, but Suzanne O'Connell is the founder of the MS Alliance of Virginia. And Suzanne and I have been doing things together for many years. We have brought our programs to, rural Virginia often. In fact, it was Suzanne that got me to start doing things in rural America. But anyway, Suzanne wants to speak to you for 3 minutes, and so I'm going to let her speak to you right now, all right? She's going to take the stage, and I'm just going to stand here and listen to her.
I just wanted to thank Stuart and MS Views and News for always thinking about rural Southwest Virginia when you're putting programs out on the road. We were extra excited about this program because Dr. Boster is a rock star in the MS world. MS patients talk about him all the time, and we were looking forward to seeing him and to meeting him. And we hope that you can still plan to come and see us, Dr. Boster. We're a fun community, and we can— I promise. You don't even need Stuart to bring you. We are a fun place. If you're ever on your way somewhere and we're within reach, you give us a call. We'll have a place for you and show you around. But I just would like to invite the MS community across the world to take our lead and know that every single person can make a difference. I started our little nonprofit as a support group of 5 people about 8 years ago, and we have grown and grown up into a large little 501c3 nonprofit located in rural Southwest Virginia, and and we are still 100% volunteer. And we welcome people from all over to join us. We've got a website. We're the Multiple Sclerosis Alliance of Virginia. And I thank you for this time, Stuart. And again, thank you for giving me the moment. I hope that we can inspire others to go forward and help their MS communities, and we'll always be willing to help.
Great, Suzanne. Thank you very much. It's always a pleasure to have you. And again, if it weren't for you, I and MS Views and News would not have started doing our programs in rural America. And to date, since we started doing that about 5 years ago, we have held, I think, over 200 educational programs in rural and underserved communities around the United States. In fact, we're doing so much that there are people in Canada that are asking us to get up to Canada and do programs. Hopefully, we'll be able to do that in a few years, all right? But we'll have to see about that. All right, so for everybody to know, thank you, Suzanne. All right, so for everybody to know, there's a handout on the toolbar. You can click on the handout, and that just shows you who's today's sponsor is of this program. So I wanted to just let you know that. And, when you get an opportunity, please go to their website, take a look at their medication. And if you have questions about it, don't come to me. See your doctor, okay? See your doctor only. All right, today's program, we have a lot to do. Dr. Boster, again, he's a good friend of mine, right? There he is. Where you go. All right. So Dr. Boster stepped in for us last week or a week and a half ago when we needed a quick replacement doctor, and I want to thank him for that. And Dr. Boster, in fact, is doing a program with us that was scheduled for a worldwide event that's coming up this Tuesday night. It's called MS Neuro TV, and Dr. Boster's again speaking there. You're seeing him so much right now because today's program actually was not supposed to be virtual. It was just going to be recorded in Roanoke, Virginia, and that would have been it. All right? All right. But anyway, you all want to see him anyway because at every program he's got something different to talk about, and he's a world of is an encyclopedia of knowledge about multiple sclerosis. I'm not going to say much more than that other than Dr. Boster started up the Boster MS Center in Columbus, Ohio. He fortunately and unfortunately opened right at the beginning of the pandemic. And so, you know, for a guy starting out in a new business, it was, you know, it's been a little tough, but he's hanging in there and he's welcoming to see patients from all over, including if you have to do telehealth call with him, which is what our topic is for Tuesday. But if you ever want to do a telehealth call with him, I know he's open to doing that with you from all over the United States. All right, I don't want to take up any more time. Dr. Boster, again, is going to speak for 35 minutes, and then we're going to do about 1 hour's worth of Q&A. All right, Dr. Boster, take it away.
Stuart, thank you so much for the invite today. I'd like to, again, say thank you to MS Views and News for such a committed effort to getting out and educating and empowering people impacted by MS in every corner of the United States. Suzanne, thank you for the warm introduction, and I will be very, very happy to come visit you in your community when circumstances work out a bit better. My name is Aaron Boster, and as always, I want to thank you for learning about MS with me. Today, I'm going to be talking to you about not a highfalutin, newfangled concept, but about how in the real world we care for folks impacted by MS, specifically with the goal of making MS boring. So let's jump into a discussion, and at the end of the next 35 minutes, I will have taught you the key, the rubric, the special sauce to make your MS boring, to help you live your best life despite having this disease so that you can thrive. Let's start off by thinking about MS. And really, in order to understand the disease process, we first have to understand the immune system. So the immune system are the part of our body which fights off bad guys. So that's the part of our body which surveys and makes sure that foreign invaders are killed and gotten rid of, and our cells are kept protective. It's literally like an army inside of us. And those immune cells are little white blood cells. They're made inside the bone marrow. And when they grow up and they first leave the bone marrow, they're kind of like college freshmen. They don't really know what they want to do with themselves. They're undifferentiated. And they go to school up at T-Cell University in the thymus. Now, T-Cell University is a really weird school. First of all, it's free to go. And second of all white blood cells are allowed entrant. So that's not like most American universities. And when you're at T-Cell U, there's only one class. Are you able to differentiate self from non-self? If I show you one of your own cells, can you identify it as such and say, hey, me, nice to see me? If I show you a virus, a bacteria, a fungus, a parasite, a foreign invader, can you identify it as a foreign invader? And if you are a good student and you study diligently and you're able to tell self versus non-self, then you graduate from T-Cell University. And upon graduation, there is only one profession. All the graduates literally become soldiers. They're given weapons and they tool around the human body, constantly checking everyone out. And when they see one of their own cells, they remember in school, don't shoot that guy. They say, hey, me, nice to see me. I hope me have a good day today. And they may give me a high five and move on. When they see a foreign invader, they stop and they remember the lesson from school and they get out their iPhone 11 and they take a picture and they text it to all of their friends. Now, every immune cell knows all about that foreign invader. And they call their friends over, 1, 2, 3, and they stop it to death and they clear the foreign invader from the body. And then they keep a picture of that foreign invader for the life of the human being. And as they do their tour of duty and they see that foreign invader a second time, they say, haha, I remember that guy, and they pounce on him again. In that way, your immune system builds an arsenal against prior invasions. And when someone tells you that you can't have chickenpox twice, they lied. You can have chickenpox 100 times. The second time you're exposed to chickenpox, your immune system has been waiting since you were 12, and it's super excited, and it clears the chickenpox before you ever have one single spot on your skin. Let's go back to T-Cell University. What happens at T-Cell University if you fail the class? Remember how I said it's a weird school? All the cells go, it's free to get in, there's only one class. I forgot to leave out one important detail. If you can't tell self versus non-self, they take you out back and they shoot you in the back of the head. They literally kill all the cells that can't graduate. So it's a little bit of a tough exam, if you will. And the importance of that is that we don't want to graduate cells that can't tell the difference. Now, every once in a while, is a mistake made, a clerical error, an administrative oversight at T-Cell University. And some student stayed up too late and didn't study very hard, and he took the class and he failed it. And he couldn't tell the difference between self or non-self. And they forgot to take him out back and shoot him. And he graduated with all of his friends. And he walked through graduation, and he was all excited, and they had a party, and then he got his first big boy job as a soldier like all of his friends, and he's tooling around the human body, and he's doing the best he can, and he sees what he thinks is a foreign invader, but it's not. It's actually part of that human being itself, but he messes up, and he thinks it's a foreign invader, and he takes a picture, and he sends it to all of his friends, and his friends all come over, and he says, that's a bad guy, and they stomp the bad guy, except the bad guy is part of you. See, that's called autoimmunity, when the immune system attacks part of your own body. And unfortunately, it keeps a memory of that part of your body, thinking it's a foreign invader, thinking it's identified a bad guy. And every single time your immune system does the tour of duty and sees that part of you, it thinks it's looking at a foreign invader and it attacks it. And autoimmunity is not uncommon. There's a lot of autoimmune conditions. In fact, you are probably familiar with several, but you might not know that they're autoimmune, like diabetes. So if the immune system attacks the pancreas and it destroys the beta isolate cells and you no longer make insulin, that causes diabetes. If the immune system attacks the joints of the fingers and the joints of the wrists and other joints in your body, that's called rheumatoid arthritis. If the immune system attacks the gut, that's called Crohn's disease. These are autoimmune conditions. Multiple sclerosis is an autoimmune condition as well. It's an autoimmune condition where the immune system inappropriately identifies the supercomputer, the holiest of holies, the brain that runs our entire body, as being a foreign invader. And every time it sees it, it attacks it using inflammation, and it causes areas of brain damage, which can manifest as attacks where people lose function and they can't see in their eye, or they can't feel their hand, or they can't move their leg, or their bladder and penis don't work. They can also accrue neurological disability slowly behind the scenes, independent from attacks. That's multiple sclerosis untreated. It's actually the leading cause of neurological disability amongst young adults outside of trauma, like car accidents. And it's a passion of mine to kick MS in the teeth. I decided to become an MS doctor when I was 12 years old. Not because my Uncle Mark had just gotten MS. No. My Uncle Mark had MS since my earliest childhood memory. But on that particular day, when I was 12, I went over to my grandmother's house where my uncle lived. And he was in the living room watching TV in his wheelchair the way he normally was. But my mom and my grandma, Nini, who's now passed, they were sitting at the dining room table or the kitchen table, and they were holding hands and their heads were down and they were crying. And they were crying not because my uncle had MS. They were crying because he was having a problem and they couldn't get a hold of their doctor, and they were scared and terrified, and they didn't know what to do, and they felt helpless and they felt alone. And this was an era before there were MS medicines. This was an era when the National MS Society and organizations like MS Views and News and the MS Coalition of Virginia didn't exist yet. And I told my mother that I would learn to do it better. I told her that I would learn how to take care of people with MS better than the men that took care of my uncle. And it became a very directed course, almost like a mission. I was a weirdo in high school that said, I want to be a multiple sclerosis doctor. And teachers would say, what's multiple sclerosis? When I went to undergrad, I did a very directed course. I did a double major in neuroscience and psychology and a minor in biochemistry so that I could be prepared for medical school. And in my first year of med school, I declared that I wanted to go into neurology. And so I did my neurology residency focusing on MS, and then I did my fellowship in MS. And I have had a very, very directed goal of helping people impacted by MS live their very best life despite having the condition. Most recently, as Stuart mentioned, I opened the Boster Center for Multiple Sclerosis, where we are now caring for families impacted by MS from around the globe, both on telemedicine, which is still 75% of my visits, and in the office. We're running multiple MS clinical trials despite this gosh darn pandemic, and we are participating actively in MS registries. I am very, very proud to be able to provide excellent, comprehensive tertiary level MS care in my hometown of Columbus, Ohio. And it's a passion of mine. Now, beyond the walls of the clinic, I believe very firmly that we have to help families impacted by MS live their best life, not just the couple times a year when they go into clinic, but every day. And we have to help you where you and when you need to be helped. And so I am committed to patient advocacy and education. And I do that through opportunities like this. I am so grateful to MS Views and News for giving me this forum and this opportunity to talk to you and to help you make your disease boring. I also leverage YouTube. I have a YouTube channel, Aaron Boster, MD. And I'm really excited. There's now 31,000 subscribers. And if you're not a member of that community, if you're not subscribed, I want you to. I want you to jump on and subscribe because every Monday I make a new video helping you up your game. I also lecture around the world to patients and families and physicians. And I am asked one question, probably more than any other question at all. What's that question you ask? When will we cure MS, Dr. B? Hey, Dr. B, when will there be a cure? Are we close to a cure? And I'm going to give you an honest and humble answer. No, we are not close to a cure. We will probably not cure MS in my lifetime. Now, I'm not saying that to be a Debbie Downer. I'm just being honest with you that our understanding of the immune system, although leaps and bounds better than when it was even 10 years ago, is still fledgling. And we don't understand enough about the immune response in the way that MS plays out for us to be in line with the cure just yet. So no, I don't think that we'll have a cure before I leave this world. But you know what we can do? You know what we can do right now? Do you know what a realistic, appropriate goal is in 2021? Today, we can make MS boring. We can make MS boring so that you can live your best life, so that you can do you and MS won't interfere. Now, let's be honest with each other. In medicine, we don't cure darn near anything. If you have diabetes, we don't cure diabetes, we treat diabetes. And I want to use diabetes as a specific example, actually, because diabetes, as I shared, is an autoimmune condition, just like MS. And back in the ancient days of yesteryear, even just like a couple generations ago, diabetes was a death sentence, because if you got diabetes, you would eventually lose your kidneys and go into renal failure. Nowadays, you might not even know that your girlfriend has diabetes unless you happen to eat chocolate cake with her at lunch. And she pulls out her little insulin pen and you say, "What are you doing, honey?" She says, "Oh, I'm giving myself my insulin shot." I didn't know you had diabetes. Having diabetes is not easy. I'm not trying to suggest that remotely. It's a lot of work, but if you work hard in the current era, you can make diabetes boring and live a normal life expectancy and a normal life quality. And I am online today with you right now to share with you that we can do that in MS. And so what I would like to do is spend the next few minutes sharing with you how I like to make your MS boring so that you can live your best life despite having this disease. And really, I'm going to teach you how to do it with 3 tips. Tip number 1, addressing quality of life, being selfish and a self-advocate. Because if I make your MS boring by giving you medicines to slow it down, and you're not having attacks and you're not having relapses and you're not having disability, but you're miserable because of chronic symptoms, then we are not doing our best job. And it breaks my heart all too often when I see someone who says, "Hey, Dr. B, I'm doing great. I haven't had an attack and da-da-da-da-da-da. But I can't go watch my son's soccer games because I can't go across the grass and I'm so exhausted I can't do anything past noon. And my fear and anxiety are such that I'm terrified to go outside and I have trouble with my thinking and my leg burns all the time. I can't have sex because it hurts and I can't achieve orgasm and I lose control of my bowels." That is not a make-believe story. That's real. And it's so sad when someone impacted by MS is not living their best life. They haven't improved their quality of life because we're not, as a team, addressing chronic symptoms. So number one, to make MS boring is to identify symptoms, things that stink, and bring them to the attention of your provider and say, hey, this is a problem and I want you to help me make it better. I, Aaron, have a pill for every ill. Now, I'm not going to give each patient of mine a pill for every ill because they don't want to take a bunch of medicines. But if a symptom bothers them enough, we want to tackle it. We want to treat it. And I am particularly interested in chasing down, ferreting out, and smushing invisible symptoms because there are a lot of symptoms in MS that are gosh darn invisible. And for the sake of our conversation, I'm going to divide two groups of invisible symptoms into the up there's and the down there's. What are the up there's and the down there's? You say, you know what the up there's and the down there's are. The up there's, you know what I mean, thinking and memory, energy, mood, the up there's. All too often, people impacted by MS have difficulty with thinking and memory. Over 50%. Some studies say upwards of 70% of people impacted by MS can have difficulties with thinking and memory. Now, this is not Alzheimer's dementia where you're not going to know who you are or who a loved one is, but it can massively impact your quality of life and your activities of daily living. It can even lead to loss of work because people can't think quickly. They can't multitask. They can't remember multiple things at once. They can't perform well under stress and pressure the way that they used to. Cognition in MS is invisible, and yet it's one of the leading causes of loss of work in the setting of MS and leading causes of loss of quality of life. And if you're having difficulty with thinking and memory, you need to bring it up to your provider because there are many, many, many things that we can do to help thinking and memory. On my YouTube channel that I mentioned, I have a playlist with probably 20 plus videos on cognition in MS. And my point here is there's a lot of work to be done. And it all starts with you saying, hey, doc, I'm having trouble finding my words sometimes. And I got written up at work for doing something wrong that I used to do all the time. Make us aware of that because we can help with that. Similarly, when we're thinking about the up there's, when we're thinking about thinking and memory, we have to think about energy because they're tied together, guys. In energy, or the lack of energy, fatigue is the most common symptom in MS. And it is a profound and pathologic fatigue that your spouse does not understand. They try to understand, and you say, honey, I'm so tired. And they say, yeah, me too. But they don't get it. I try to help spouses understand by saying, imagine that after work on Monday, you came home and had dinner with your family, and then you helped do the dishes, and then you didn't go to bed. You just stayed up and watched my YouTube channel all night. And then in the morning, you took a shower and had some coffee and splashed some water on your face, and you went into work and you worked real hard all day long on Tuesday, and you came home Tuesday night and you had dinner, and then you did the dishes, and then you didn't go to bed. You finished watching all the other videos on my YouTube channel. So by Wednesday morning, you've seen all the YouTube videos I've made, and you haven't slept in 2 days. And I'm going to come over to your house, and we're going to go on a walk for about 5 or 6 miles while we discuss what it feels like to be tired. That's the best example I've come up with where people impacted by MS have nodded and said, yeah, Aaron, that's kind of a little bit what it's like. It's a monster, and it's treatable. It's treatable by behavioral measures. It's treatable by medicines. It's treatable by treating the underlying disease process. Again, I have multiple YouTube videos on how to treat fatigue. On this platform, on MS Views and News, Stuart has a library of brilliant MSologists, many of them talking about fatigue and ways of beating it. And if it's bothering you, it starts by you telling your doc, hey, I'm really, really tired, and I can't get through what I need to get done. I need your help because we can help you with that. When you're thinking about the up there's, and you're thinking about cognition, and you're thinking about energy, you have to think about mood because it's related. And it turns out that people impacted by MS are twice as likely to experience depression. They're twice as likely to experience anxiety, and that erodes the quality of your life. Did you know that if you have MS and you're untreated in your depression, your neurological status gets worse faster? Seriously, treating your depression does more than just make you feel better. It actually slows your disease. It's super, super important. And again, it all is predicated on you letting your doc know that, no, my mood's not very good right now. I'm really sad and blue. We actually screen each patient every visit for cognition by doing a cognitive test, for mood, and for energy by patient-reported measures that we give out because we take the up there's very seriously. Not more seriously, however, than the down there's. The up there's are important, but I like the down there's just as much. And what are the down there's? You know what the down there's are. You know the down there's. Bowel, bladder, sexual function. I mean, come on, down there's. Because those are invisible symptoms. People impacted by MS can have problems with the down there's. And sometimes it's embarrassing to bring it up to the doctor or to their spouse. Sometimes it leads to people having a very, very poor quality of life, despite the fact they're not having attacks or they're not having disability, because they don't want to leave their house because they're embarrassed they may pee their pants or poop their pants. And that's really serious. And we can address the down there's. You think about bladder function. I want to ask patients, are you having urgency? Do you have to sprint to the bathroom? Do you have frequency? You're getting up all the time to go. Nocturia, you're getting up all night long. You keep having to go to the bathroom. Do you ever have urinary abstinence where you wet the bed or where you wet your pants and you didn't mean to? Are you having urinary tract infections? Or are you having the other problem? You can't empty. You push and you go to the bathroom and 2 minutes later you have to go right back, or you stand up after peeing, you have to sit right back down and finish. There's a lot of things that can go on with bladder, and we can take care of them. And oftentimes we can take care of them without a urologist. I have a bladder ultrasound in my clinic, and I can scan your bladder and I can help you figure out, is it the first problem I described or the second, or are you unlucky and you have both? And I've got a pill for that ill. There are behavioral measures that we can take to make that better. And there are medicines that we can give you to make that better. And we can call an expert urologist when we need to. And the whole point is, I want you to be dry. I don't want you to wet yourself, and I don't want you to have recurrent urinary tract infections, and you don't have to. You just got to tell me that it's going on so I can help. When you think about the down there's and you think about bladder, you got to talk about bowel function. Bowels are something that we want to move, right? And I want you to be able to move your bowels when you choose to without an accident. I don't want you to have diarrhea, and I don't want you to be super constipated. And constipation is very, very common in MS. I'm talking super common. I have a 2nd degree black belt in how to make you poop because so many of my patients are bound up that I have had to become really, really competent in how to make you move your bowels. And every MS neurologist that I know is competent in how to make you move your bowels. And so if moving your bowels is an act of Congress, if it's like something you want to write a letter, Mom, I did it, maybe we should have a conversation about that. And there are changes that we can make in exercise, in sleeping habits, in diet, in water intake. There are medicines that we can take away, and there are medicines that we can give you, all with the goal of having a fantastic BM. Now, I'll share with you, just in the interest of time, one pro tip to poop. And this has to do with the way that your body is wired. When you put a hot beverage in your mouth and it hits your stomach in the morning, 20 minutes later, your bowels try to poop. That's called the gastrocolic reflex. And it happens again when you eat lunch, when you put a meal in your belly, and again when you eat dinner and put a meal in your belly. About 20 minutes later, your colon tries to evacuate. Now, in the setting of MS, sometimes you lose that feedback, so you don't feel the sense of fullness that you need to move your bowels, but it's happening. So here's the pro tip. 15, 20 minutes after you have your first cup of coffee or tea in the morning, or after you have your nice lunch, go sit on the john. Try to move your bowels. That is the best window of opportunity when you can get in there and have a possible outstanding bowel movement. So we got to think about the down there's. We've got to talk about pee and poop. We've got to talk about bowel. We've got to talk about bladder, and we have to talk about sexual function. Because I want you to live your best life despite having MS. And if you have difficulties with the bedroom, that's not going to allow you to have your very best life. And so we can't be shy about this. We have to bring it up. We have to talk to our providers about it. Look, man, if you're having a difficulty with arousal, you're just not that excited, there's reasons for that. And we can talk about that. And oftentimes we can make it better. If you are having a difficult time with adequate lubrication or erection, we have ways of making that better. If it is challenging you to achieve orgasm, there are things that we can do about that. And that involves a multi-step process. That oftentimes involves talking to our sex partner. That oftentimes involves critically looking at the medicines we're taking and maybe removing some naughty ones, maybe adding some medicines. There's medicines for female libido. They exist. There's all kinds of things that we can do, but it's all predicated on you bringing up to your provider that you got a problem with the down there's, that you have invisible symptoms that are not invisible to you, and that you're trying to live your best life and you want help. So when I start to talk about how to make MS boring, the first thing that I want to think about is treating chronic symptoms, all right? Because I want to improve the quality of your life. And I gave 2 examples today, the up theres and the down theres. Now, the next thing that we need to do in order to live our best life despite having MS is we need to identify and treat MS attacks. MS attacks are not something you have to go looking for, right? You don't have to ask your spouse when you're in the car if the front left tire just blew up. That's never a question. Hey, honey, by the way, real quick question. Do you think the front left tire just blew up? Not so, right? That doesn't happen. Because if the front left tire blows up, you don't have to wonder, you know. And if you're having an MS attack, you know. And I want to talk a little bit more about that because when you're given a chronic diagnosis, any chronic diagnosis, MS, rheumatoid arthritis, diabetes, cancer, and then you have a funny symptom like your nose itches, you're going to ask a rational question. Is the nose itching related to the new diagnosis, right? And so I want to teach you a way to answer that question with MS, the 24-hour rule. MS attacks are caused by inflammation, swelling. So let's pretend you got mad at me and you socked me in my jaw and my face got all puffy. Tomorrow it's more puffy, right? Because the inflammation doesn't go away in a couple hours. And if you wake up and your nose is itching and you're wondering whether it's related to your MS, could it be an attack? I want you to ask yourself, self, how long has it gone on? And then you'll say, about 30 seconds. You'll say, oh, well, then I don't need to worry about it. If it goes on for longer than a day, now I want you to call your provider and say, hey, my nose has been itching and it's going on for longer than a day, and it could be inflammation caused from an MS attack. Could you check me out? And the provider needs to say yes, they need to check you out. We need to do a urinalysis to make sure you don't have a urinary tract infection. We want to examine you to make sure there isn't another cause for your nose itching. And if in fact we think it's an attack, we need to give you steroids to hasten recovery. Now notice that this was not an exchange over the telephone. Hey doc, not feeling so good. Oh, I'll call you in some steroids to your pharmacy. Bye. No. We don't want to do that because there are risks with steroids. And we want to make sure that we know why we're treating. We want to rule out an infection triggering a pseudo attack. And this is important, guys, we need to follow up after we give steroids. I don't want your clinician to give you steroids and then see you in 6 months. I don't think that's the best practice. I think a better practice is that you come in 4 to 6 weeks later and you're evaluated to make sure that it's better. Because if it's not, there are things that we can do. Sometimes patients say, Dr. B, I'm not going to tell you if I have an attack because I don't want you to make me take steroids. I don't make people do things. I can't even make my kids do things. I'm not going to make you take steroids. I'm going to ask you to take steroids and you can say no. And I'll say, okay, but I still need you to tell me that it's going on because that's one of the ways that I measure your disease. And so if we're trying to live our best lives and make MS boring, if we're trying to do exactly that, we need to manage chronic symptoms the way that I discussed, even invisible symptoms like the up theres and the down theres. And we need to identify when there's new neurological deficits that are lasting longer than a day and bring it to the attention of our provider. I don't want you to play Dr. Google. You can play doctor in the bedroom if you enjoy, but don't play Dr. Google because that's going to lead down a rabbit hole where you're going to get yourself scared and confused potentially, unnecessarily so. Instead, holler at your clinician and say, hey, I've got these new symptoms. They're going on for longer than the day. I need to get checked out. Now, in our quest of making MS boring, there's one last step, and it's maybe the most important. And I summarize it by asking you if you are 5 for 5 in your fight against MS. That's right. I want you to be 5 for 5 in your fight against MS. If you want to make MS boring, I expect for you to be considering if you're 5 for 5. And if you're 4 for 5, we got to do a little better. And if you're 3 for 5, there's definitely some things that we need to do. If you want to make MS boring, I need you to be 5 for 5 all the time. What's that? Oh, you want to know what it means to be 5 for 5? Excellent question. Well, let's talk about it. We've got some time left on the clock. Let's discuss what it means to be 5 for 5 in your fight against MS. Now, being 5 for 5 in your fight involves paying attention to 5 aspects of life and adhering to some very, very simple concepts so that you can thrive despite having MS. And the first thing that we want, number 1 in being 5 for 5, is to not smoke stuff. That's right. I don't want you to take a carbon-based plant matter and light it on fire and then suck in the smoke. because that's super pro-inflammatory and it's really, really not good for your lungs, but it's also not good for your brain. It's not good for your entire nervous system. And it increases the risk of developing MS if you smoke by 50%. So if you're at risk for MS and you smoke, you double that risk. Ah! And if you already have MS and you smoke, you speed up MS by almost 50%. Allow me to repeat, if you smoke cigarettes, you're speeding up your disease by almost 50%. And if you stop smoking, you slow it back down. And I think that's like super duper uber important. Now, I said don't smoke stuff because I'm not just talking about tobacco. I'm also talking about wacky tobacco. I'm talking about medical marijuana and cannabis. And I am a medical marijuana recommender. I think that MMJ has fantastic value in treating some MS symptoms, but I don't want you to take a joint or a blunt and light it on fire and suck in the marijuana smoke because, again, that's super pro-inflammatory. There are other ways of consuming cannabis like edibles and tincture, and even a vape pen is a little bit better than smoking. So number one in your quest to be 5 for 5 in your fight against MS is to not smoke stuff. Now, there's actually an advanced version of the number one, don't smoke stuff, and that's to start to pay attention to other cardiovascular risk factors. And so maybe Stuart will invite me back one day and I'll get into the deep, deep discussion about the deep understanding of 5 for 5. But for now, let's not smoke stuff. And if you have untreated diabetes or high blood pressure or morbid obesity or inactivity, those are things that we need to work on also if we're going to live our best life without MS or with MS. Now, number 2 in being 5 for 5 is to supplement low levels of vitamin D. So it turns out that vitamin D levels pre-puberty augment or alter the risk to develop MS. And so if you have a low level of vitamin D pre-puberty, you increase your risk to develop multiple sclerosis. And it looks like if you supplement vitamin D3 and drive your level above 50 before puberty, it's actually protective against getting MS, which is flipping awesome. And I make sure that all of my patients who are parents know that so they can talk to their children's pediatrician about supplementing their children's vitamin D. We look at vitamin D25OH, that's the lab. And I want that lab to be above 50 and below 100. And if you're one of my MS patients, we check your labs to make sure that your vitamin D is above 50 and below 100 once or twice a year. And we give you supplementation with D3 to drive it up. Now, one of the best ways of getting D3 is actually to be in the sun, which is problematic if you live in Columbus, Ohio, because 7 months out of the year, we really don't have a lot of sun. And it's also problematic if you live in Florida, because it's insanely hot outside and you get a sunburn and you can have cancer and stuff. And so that's a problem. But if you go outside for 15 minutes shirtless and you're exposed to the sun with most of your upper body exposed, that will create 5,000 international units of D3. So that's free and that's highly effective. And that's another thing that I think people need to think about when you're trying to up your vitamin D. So the first thing we want to do is not smoke stuff. The second thing we want to do is take vitamin D. Now, if you want to kick that up a notch, we could talk about diet and nutrition. And that's a whole nother discussion. It's a very, very involved discussion, but really it's an important aspect of MS. I've got a bunch of videos on my YouTube channel where I talk about my opinions about diet and nutrition and MS. Just to talk about them super briefly right now, I want you to up your water game. So periodically during the lecture, I'm sipping on this fantastic carbonated water. And I'm upping my water game. I want you to drink a glass of water with each of the 3 meals, and I want you to drink a glass of water between each meal. We got to up your water game, and that makes a big, big difference in constipation and in bladder control and in energy levels and in spasticity. It does a lot of things that you would be shocked at. Try it out if you don't believe me. Now, we also want to eat real food. We don't want to eat fake food. What's fake food, you say? Fake food is fast food. That's not real food. It doesn't rot. Real food rots. Real food doesn't have ingredients that you can't pronounce. So if you read the ingredients and it's a bunch of tetrahydrochloride, blah, 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 that's not food. That's a chemical. Don't eat that. Don't eat fast food or heavily processed foods or soda. Now, we could talk for hours and hours about diets for MS and the evidence or the lack of evidence thereof. But what I just mentioned is really hard to do and really, really valuable in MS. And so if you want to take supplementing vitamin D up a notch, we get into how we manage nutrition in MS. Now, number 3 in your quest of being 5 for 5 in your fight against MS, number 3 is to exercise as part of your lifestyle. And exercising as part of your lifestyle is not revisiting the glory days of high school football with 2-a-day practices, where if you could run a mile, then you could run 2, and if your friend can run 2, then you could run 4, but if you miss practice, then you don't do anything at all. That's this high school mentality that doesn't fare very well in the real world as adults. We have families and children and responsibilities and honey-do lists and work. I need you to exercise as part of your lifestyle. Now, what I mean by that is, well, let me give you an example. I have a lifestyle of brushing my teeth, right? I don't brag about it. I don't post on Twitter. I brushed my teeth. It's not something I talk about. It's something that I do. I do it twice a day. I brush my teeth in the morning. I brush my teeth when I go to bed at night. And if I forgot to brush my teeth, which is a little gross, I might notice that it's gross and I'll just get up and brush my teeth. And if you can adopt a lifestyle of exercise where you find an activity that you don't think stinks and you do it a couple times a week, and if you don't get to it one day, there's no punishment and you don't get really, put in the naughty corner, you just do it the next day. I need you to find an activity, whether it be yoga or tantric sex or walking for exercise or turning a hand crank or doing Pilates. I want you to find something that you don't hate, and I need you to do it as part of your lifestyle, because people impacted by MS that exercise as part of their lifestyle slow their disease progression. They're less disabled at the end of their life. They buttress against attacks. They handle attacks better. They think more clearly. They have more energy. They have less fatigue. Are you picking up what I'm putting down? Now, number 4 in your quest to being 5 for 5 in your fight against MS is to take a DMT and make sure it's working. Taking an MS medicine, a disease-modifying therapy, is critically important if you want to make MS boring. And I want you on the most effective disease-modifying therapy that you're comfortable with. And I want you to constantly check and make sure it's working. We don't marry our therapies, we date them. And if the therapy treats you like a lady, and is a good dancer and is polite around the family and goes to the same church and you get along great, groovy, keep on dating. But if he starts to act the fool and he misspeaks, or he comes home drunk, or he steps out and goes out with another gal, or what have you, I think you're going to have to take that DMT out of your phone book and delete him off Facebook and tell him that you're going through some things and that you need some time, and you'll call him, and then we're never going to call him, and we're going to find a different DMT, because we need to make sure it's working. How do you make sure it's working? Well, the first thing I do is I ask you, because you're a you expert, and you'll tell me if you've had an attack or if you've failed the litmus test of life. And that's not okay if you are. We have to talk about that. We can then do the MS Olympics when you come into the clinic and we run you through the MS testing that we do with the 9-hole peg test and the timed 25-foot walk and the symbol digit modality, all of these various validated tests, and our neuro exam where we're trying to see if your functioning is the same as it was last time we examined you. And then the third thing is to look at structure, to look at MRIs. And I think that we need to get an MRI of your brain at least once a year until you're 60, and the neck probably every couple years. We want to constantly be evaluating, is this drug doing the best that it can for us? That's number 4 in trying to be 5 for 5 in your fight against MS. And to wrap things up today, number 5, which is one of the most important and least understood of the 5 for 5 plan, is mindfulness. It's a daily moment where you dedicate a couple minutes minimum every day to be in the present moment. And you might say, well, that sounds silly, but it's not. And I dare you to try it out. I've been practicing mindfulness for a couple months now, and it's changed my life. I practice something called shower meditation. And if you think that sounds weird, it is. But I have a lifestyle where I shower every morning. And so what I've started to do is during my shower, I sit down on the floor of the shower, cross-legged, and I sit in the water and I close my eyes and I practice breathing for like 5 minutes. And I go through a couple really easy breathing exercises where I envision counting and I see the numbers and some other things that are kind of easy and fun. And I'll tell you, when I finish that 5 minutes, I'm centered. I'm doing better. I spend 5 minutes focusing on the now, not worrying about the clinic that I was about to start or what was going on with my children or my family or what I needed to do that evening. Or I didn't spend that time worrying about what I did wrong yesterday or what things I missed in clinic the day before or what problems that I haven't addressed yet. I put all that aside for 5 minutes and I exist in the now. And I want you to do that every single day. I want you to be 5 for 5 in your fight against MS. And that's going to help you on your road to making MS boring. My name's Aaron Boster, and thank you for taking a few minutes to learn about MS with me. I want to invite Stuart back so that we can tackle some questions.
Awesome, awesome. Thank you. That was a great, great talk. We have a lot of questions that are coming in. Some just don't understand some of your terminology. Like an anonymous person just wrote in, what is tantric sex?
What is tantric sex, they say? So tantric sex is very important. It's the concept that you could engage in sexual intercourse for hours and hours without orgasming. It's discussed in some Eastern cultures, and if you can become a master of that, God bless you.
Great. Another one from something that you just mentioned is to describe, please, the PEG test.
Yep. So when we're assessing someone with MS, one of the ways that we do that is by physical exam findings. And so the neurologist may do some things where they test your strength, or they have you touch their finger or see how fast you tap. And those are assessments of the upper extremity. The most validated measure is actually called the 9-hole PEG test. And so there's a board with 9 holes and then a little divot that's got pegs in it. And under time, we sit there with a stopwatch, we say, go, and you pick up a peg and put it in the hole, and then you put all 9 in, and then you take all 9 out. And we do it for time. And an average healthy control does it in about, I don't know, maybe like 15 seconds. And if you're slow, then it tells us something's wrong. And in fact, a 20% slowing is statistically significant. And so if you do that test and your left hand is a lot slower than it was last time, I now know something's wrong with the left hand and I can laser focus figure it out. So the 9-hole PEG test is a very important test for hand function.
Great, fabulous. Thank you for that. Hey, again, I just want to say thank you for all that talking that you did before. I mean, it was great. I mean, I know we could have you speak for hours, but then how are we going to do hours more of questions, right?
And I'll be faster with the questions. I promise to try to do it tighter.
Right. That's what I was going to ask you, to be a little bit tighter with the answers so we can get on to each one, okay? All right. There are a lot of people, of course, saying excellent talk. Thank you, blah, blah, blah. And we'll get to all those later on. All right. Next, Monique says, why only have yearly MRIs until the age of 60? What happens after 60?
So Monique, that's a very good point you picked up on. Now, there isn't a international agreement about how often to image and when to stop or start. So some of this is best practice from organizations like Magnus or the National MS Society. But what I said about an annual MRI of the brain until 60 is something that Aaron, made up, right? Aaron made that up, having done MS for about a decade and a half. After the age of 60, the likelihood of new spots is less often. It can still happen, but it's less often. And so I think if you're clinically stable after 60, I may allow us to go every other year, just because you're less likely to see a new spot and we can be more judicious with your insurance money.
Great, thank you. All right, next, how to cope with secondary progressive multiple sclerosis and the difficulty of walking.
So SPMS is a form of relapsing MS, and being 5 for 5 in your fight is exactly what I want you to do. And if you think about number 3, it's exercise. And that may be hard when you have difficulties with mobility. And so you may need to get a physical therapist, or you may need to get aquatic therapy, but that's how you're going to keep your walking as good as you can.
Thank you. Thank you. By the way, you use the word provider many times, and I just want to let people know who don't know what provider is. He's only talking about your medical doctor, okay? So if you hear that term.
Well, a medical doctor or a nurse practitioner or a physician's assistant, they're all providers. And it's not just MDs, it's DOs, it's NPs, it's PAs. There's a lot of people on your team that are really, really there to help you. And so we want to involve the provider in the care model.
Okay, thank you for that. All right, person wants to know what do you feel is the long-term prognosis for people with MS?
So it's variable. So it's not one size fits all. And some people, they wrap up their lives and their MS has not made them very disabled at all. And some people have very significant problems. And I don't think that you can give it's normally like X. What I can tell you is untreated, it's much, much worse than treated. And treated, we can make it boring and seemingly make it stand still. Untreated, we can't do that.
Okay, thank you. By the way, for everybody, if I don't mention your name, it's because it came from the original list of when everybody was registering, leaving questions, all right? You hear your name, it's because you just did it online. All right. There's a Robin writes, in terms of the up there's that you speak about, and you say there are meds out there to help. You've communicated with your MS neurologist. They are not familiar with those kinds of meds to help. Oops, something just jumped. To help that you need to see a psychologist, but they can't get it right either. What do you do?
So here's an example where advocacy, particularly self-advocacy, is super important. And what you could do is you could print out information from, say, the National MS Society talking about the medicines like Provigil, Nuvigil, Adderall, Ritalin, bring it to your MS neurologist. You could print out some articles that demonstrate that it's a really good idea and say, hey, I've done my research. I think this would really help me. I want you to help me do that. And if they say, look, I'm not comfortable, and you're having trouble getting into a psychiatrist who would do it, then lean on your MS neurologist. Say, listen, if you can't help me do this, and you're going to put me in touch with the right person, help me do that. Get me in front of the right person, because it's my life and it's my energy and I need you to help me. So you have to be an advocate and you have to push a little bit. And I think that's important. I really do.
Okay, thank you. Now I'm going to be trying to combine questions as much as possible. Please know, everybody, if you did ask a question when you registered, please do not ask it again online, because I have MS and I will forget. Okay, and I don't want to ask the same question twice. All right, so next one is, how can I overcome malaise and do some exercises? And to tackle on to that, can fatigue happen at any age?
So sometimes we can overdo it with MS, and we don't realize that our functional reserves are really small. And so even seemingly a tiny bit of exercise leaves us in bed the next day. And the secret to overcoming that is to start very, 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 very slowly. For example, let's say that we're going to use a treadmill. You might start off walking for a minute, 60 seconds. That's it. I'm being serious. You get on the treadmill and you walk for 60 seconds and you get off. That's all, that's all you do that day. And if you can consistently do that for a minute, over time, you can work up to 2 minutes. Now notice we didn't start off at 15 minutes. Maybe you complete 15 minutes, but then you're in bed. And so we have to slowly build up your reserves. Fatigue can occur with anyone, although it tends to get more prevalent as the disease moves forward. And timing of the day matters. So you may find that the best time to exercise is right when you wake up, when you have the most spoons and the most energy, not after work when you're exhausted. Lots to think about.
Okay, thank you. By the way, there's many Amy's on here. One Amy writes, do you find stress can exacerbate MS symptoms? Are there any recommendations that you have for this?
Nobody goes home at night and says, honey, let's get stressed out. Like, that's not a conversation between family members. And stress worsens MS symptoms. I agree with you. Stress makes MS symptoms worse. And I hate it when doctors say, well, honey, just remove the stress, as if you could like cut it out. But I think what we have to do is we have to manage stress. What's one way to do that? The fifth element of being 5 for 5 is mindfulness. It's a daily practice of existing in the now, and that helps manage stress. And if you don't believe me, try it, because it's amazing and it works really well.
Thank you. So one Amy must know the other Amy, because the next Amy writes, can you explain experiencing new MS symptoms without changes, and also new lesions observed on MRIs she wants to know about as well?
Yes. So there's an old idea that all symptoms in MS come from an attack, right? And that's not true. People can have worsening because you have an attack and you don't fully recover. And I'll use an example of someone has an optic neuritis and they can't see, and then their vision comes back 50%. They accrued disability from incomplete recovery. But that's only one of two ways that people can develop symptoms or worsening. The other option is progression, which is independent from a relapse. So we call that PIRA, progression independent from relapse activity, PIRA. And that's another way that people can have progression. And it can occur in the absence of an attack, and it can occur in the absence of a new spot, and it's not uncommon. So knowing that both are available as ways of getting worse is important, and knowing that MS medicines can slow down both are really, really important.
Great, thank you. Before I ask the next question, I want everybody to know that next week, like I mentioned earlier, Dr. Boster will be back speaking about telehealth. The very next night, we have a special program that I will be speaking with an MS patient who's also an RN, and she will be discussing aging with multiple sclerosis, a very important topic. And in fact, the question here is, how do I know if something is MS or old age or depression or just laziness? So I'm going to let Dr. B answer.
So you bring up a most excellent point that human beings are not textbooks, and we don't experience an attack. We experience symptoms. We experience stuff, and we don't always know exactly what caused the stuff. Now, earlier I said it's okay to play doctor in the bedroom if you like that, but it's not okay to play Dr. Google, and that's what I meant. If you have a new symptom, I don't want you to stress yourself out Google searching, trying to answer what it is. I want you to bring it to the attention of your provider, your care team, and I want them to help you figure it out. Because you're right, sometimes it's confusing whether something is, quote, just getting older or, quote, from MS. And the provider can help you sort that out. And oftentimes what we see is we have overlap, but that doesn't mean that we can't make it better, and we can. And you need to tell your provider, hey, I'm having this problem and I'm not sure what's causing it, and we'll help you sort it.
Right. So many times people see me, having pain, and I say, I think it's more age related than it is MS related. So, I mean, there's a difference between neuropathic pain and orthopedic pain. I can feel the difference, so hoping others can recognize it as well. All right, next person says, I have PPMS and I'm terrified of continued progression and what that means for how I live my life. I'm a 41-year-old father of 3 small children. I have a lot of time left with this disease. What expectation can I really have to make MS boring?
I think that with the earliest application of the most effective disease-modifying therapy, I think with an exercise as a lifestyle, a commitment to exercise, I think with a commitment to eating healthy, eating real food, supplementing vitamin D, I think by not smoking and by focusing on mindfulness daily, you have a very high expectation of leading a boring life despite MS. I believe that firmly, and that's exactly how I practice in my clinic.
Okay, thank you for that. Next one, I need some pointers on how to manage my energy and strength throughout the day. I think you did that as part of your 5 for 5.
I'll simply say you got to identify when you've run out of energy, and you need to plan events to occur at the best times. That might be first thing in the morning, for example.
Okay, what do you feel is the best way to repair cognitive issues?
I think there isn't one size fits all. I think healthy eating, minimizing alcohol and drugs. I think not smoking. I think exercising is key. I think doing cognitively stimulating tasks like Sudoku puzzles and crossword puzzles and reading books. I think all of these things matter. I think treating depression and fatigue is critical. I think it's very, very important to remove non-essential medicines and polypharmacy. And lastly, there are medicines like Provigil, Nuvigil, Adderall, Ritalin, which can massively help in this area.
Okay, thank you. Would exercise be safe for keeping depression away?
Yes, exercise is an antidepressant. And amongst its other benefits, we've seen in the general population and in MS that folks that exercise manage depression much better.
Great. Person writes, how often should I have an MRI? My neurologist won't refer me for one as there's no clinical need. The last one was 7 years ago.
Respectfully, I think that's crazy. And I think that the reason we get an MRI is because there's no clinical indication. So if you have an attack, I don't need an MRI. I have you telling me there's an attack, or I can see it on your exam. I want to get an MRI when everything's awesome sauce, and I want to make sure I'm not missing something under the hood. So once a year, I'm supposed to take my car to the mechanic, not because there's something wrong with my car, but because it's a good practice to have them check it over. And sometimes they'll call me and say, hey, looked at your car and your front left tire is really low and we're going to replace it. And I'll say, well, I didn't notice there was a problem. And the mechanic will say, exactly, I'm going to replace it before it's a problem clinically, right? So we do the same thing. Now, the human being is a human, they're not a car. But the MRI is a diagnostic tool to look behind the scenes, under the hood, to see if there's new lesions, new brain damage that the person's not aware of yet. And if you see that new brain damage that the person's not aware of yet, That's like identifying a problem in a car before it's a problem on the road. We can help address it ahead of time. So I like to get an MRI of the brain once a year, at least until you're 60. And I like to get an MRI of the neck every couple of years. And I do it because you're doing well, not because there's a problem.
Okay, thank you. Rebecca wants to know, how do I get doctors to quit having tunnel vision with their disease? Because everything is blamed on her MS rather than looking at the bigger picture.
So one tool is the form that's available on MS Views and News website, where you can print out this form and you fill out these questions, where you write down your medicines, you write down the things that have happened recently that you want to make sure you talk about, you write down all the things that you want to make sure are discussed during the visit. And then you march into the visit with that in front of you and you say, doctor, I have this list of things that I need to review with you. And ethically and culturally, the doctor's going to be on the hook to go through that with you. And it gives you a forum not to forget what you want to talk about and to push the point. Listen, I'm concerned that you're not thinking globally enough about my symptoms. And you can write down, would you consider a referral to a different kind of doctor to think about it from a different angle? Or would you help work with me to think about it from this angle? You're allowed to do that. Self-advocacy and proper planning, bringing in a list, is a great way to start that conversation.
Great, thank you. All right, continuing with MRIs. What do you feel about MRIs, the power of the magnet to be used for people of color? I'm combining this, everybody, with a lot of different questions, right? For people of color, and are they yet using 7T?
So there's no evidence that ethnic diversity requires different kinds of imaging. So someone who is Hispanic or Asian American or African American or Caucasian, they can all use the same imaging techniques. We don't have to change the strength of the magnet for that. Now, the strength of the magnet does matter. And I would not allow someone to have an MRI on something weaker than a 1.5 Tesla scanner. A minimum strength requirement is a 1.5 T. I do all of my imaging on 3T, which is a stronger magnet and a better picture. I have done research and published a paper on a 7T magnet back when I used to be a professor at Ohio State. And we had a 7T research magnet. And it's a really cool, fun tool, and it's not prime time yet. And it's a very high-powered way of looking at MS pathology, but I don't think that it's standard. If you are able to have a 7T, it's really cool to look at, and I've used them in research, but I still think a properly protocoled 3T in the modern era gives you outstanding MS images.
Okay, thank you for that. Now I'm going to take just a couple more of MRI questions because we have a lot of questions, all right? And we only have Dr. Boster. I did tell him only an hour, but I'm going to ask him if we could have another hour. So it's going to be tight, though. I know he's going to be tight. All right. Yep. So sticking with MRIs, all right, people want to know about contrast and whether or not they should have it and the dangers that are involved. I'm combining a whole bunch of things here, right?
Yep.
And whether you recommend for a person to always get contrast or when they should actually have it or not have it. Go ahead, your turn.
So when you have an MRI, you're taking a picture of the structure of your brain. And at some point during the MRI, the tech will take you out of the gantry and they've got an IV in your arm and they inject you with this dye and it makes you have this warm rushing feeling. Some people feel like they're going to wet their pants. It's like this whoosh, and they're put back in the scanner, and the images that they obtain right after they give you the dye allow you to see the blood vessels, because now there's dye inside the blood vessel and they light them up so you can see them all. And in MS, we're not really looking at the blood vessel. We're looking to see if the dye leaks out into the brain, because there's a barrier aptly called the blood-brain barrier, which separates the bloodstream from the brain. And if the blood-brain barrier is intact, the dye doesn't leak out. It stays in the blood vessel. But if there's an area where it leaks out and makes a big glowing circle, that's called an enhancing lesion. And that tells us that there's a new lesion now at the time that we're obtaining the scan. Because lesions all enhance, every single one of them enhance, and they only enhance for a couple weeks, and then they stop enhancing, and there's a white spot, but it doesn't glow anymore. Using GAD, the contrast agent, to make the diagnosis, I think, is a requirement, because the diagnostic criteria utilize the presence of contrast to help confirm the diagnosis in some cases. And I really think it's important. Getting GAD for follow-up is also very important because it teaches me more information. If I see a lesion and it's enhancing, I know the age of it. I know it's new now. Now, there is a lot of controversy about contrast. And there's two kinds of contrast agents. There's linear contrast agents, and there's macrocyclic contrast agents. Simply put, linear is bad and cyclic is good. Macrocyclic molecules do not get deposed in the brain. They don't get sequestered. Now, we have to make sure that you have normal kidney function. And there's been a lot of lay press and people making up concerns about contrast. And there's also medical concerns if you have damage to your kidneys or you're using linear molecules. So my recommendation is that you get contrast. I always want with and without contrast. But if you tell me no, I'm not going to argue with you. We just won't get contrast. And you have to understand that I don't learn as much information. I still learn plenty, probably 80% of the information, and we're going to miss some. And that's okay, because I don't want to do something you're not comfortable with. And so it's a discussion point. Excellent question, and thank you for asking.
Great. Okay, thank you. Now let's move on to something else. Let's move on to a question that many are asking. How long should they be using DMTs? Should they stop when they're in their 60s? Should they continue? And I know your answer, but you could say it real quick.
So first I have to breathe deeply and be calm, because I'm so enraged that there are these nonsensical neurologists running around trying to figure out ways to take people off therapy. So give me 1 second, Stuart. All right, hold on.
Okay. You're not dead yet, everybody.
All right, so now that I've collected myself, I want you to stay on a DMT as long as you have a nervous system with functions you like seeing and eating and orgasming, and as long as you have an immune system that risks attacking it. And the likelihood that you have an attack when you're older is less, but the likelihood that you bounce back is less. And these medicines slow brain volume loss, and they slow progression, and we want that, even if you're older. So keep on keeping on. I don't think we should stop medicines. I do think it's okay to de-escalate medicines, but I think it's a really not good idea. And all too often, I've seen people come off medicines in their 60s and have bad progression or disability or attacks, and I put them back on therapy.
Great, thank you. Can you quickly describe the difference between relapse remitting, secondary progressive, and primary?
Yes. So there's two kinds of MS, relapsing and progressive. Relapsing MS is characterized by relapses or attacks, flares, exacerbations. And if you've ever had an attack, you have a relapsing form of MS. Now, if you've had a relapsing form of MS but have not had an attack in many years, and you're accruing neurological disability independent from attack, we call that secondarily progressing or secondary progressive MS. It's a type of relapsing MS, and you're still at risk for attacks. Primary progressive MS means that from the get-go, primarily, you started progression without attacks. And those people generally don't have attacks, or maybe have one in their whole life. It's very rare. And both are types of MS. And we use the terms relapsing, remitting, secondary progressive, and primary progressive to describe the way it looks. And I look forward to getting rid of those dumb terms because they do the disease a disservice. I look forward to the future when we actually define MS appropriately by the immunology and the genetics, as opposed to this outward description.
Great, thank you. Thank you very much for that. That took care of a lot of the questions as well. There is a person, though, that's asking about being diagnosed at a late stage in life at 65 and has never been on a DMT due to the risk of benefit. Do you find anything wrong with that?
Yeah, a lot of things wrong with it. So I don't think 60 is old. They said end of life. Nuh-uh. 60 is the new 40, my friend. And you've got 20, 30, maybe 40 years in front of you. So you got a lot of life in front of you. Second of all, I disagree with the risk-benefit comment, because there are some medicines that are extremely, extremely safe. And there are other medicines that are safe if you know how to use them. And I have failed 0 times finding a medicine that someone can tolerate that they find safe. We can find something. So I think that in order to live your best life, diagnosed at 60 or diagnosed at 6, we need you on an MS medicine to slow it down.
Great, thank you. I have to go back to MRI just only for one quick question. It's not about the MRI itself, but Joe, who lives in the United Kingdom, is asking how she can convince her neurologist to give her an MRI because they have not done so in so many years.
So I think for starters, Joe, you can print off the Magnus recommendations, which is a group out of the UK, which suggests that you should get imaged. You could print off the National MS Society recommendations from the United States and print off the recommendation, or the Consortium of MS Centers, all of whom recommend that you do serial imaging. You could just say to your neurologist, look, it's my body, it's my brain, and I want to know. And so order the thing for me because I want it, because I want to make sure we're doing the best job. You can stress to them that it's your life and your body and your brain. And you can be an advocate for yourself. Those are ways that I would start. I think I would have a discussion and explain that you think it's important.
Great, thank you. Do you find that there's a problem with people who have a deficiency of B12 or magnesium or any of the other vitamins that could cause a flare-up?
So I don't think that a nutritional deficiency would necessarily trigger an attack, but a nutritional deficiency can cause a lot of neurological problems. You give an example of B12. If you have depleted B12, you can have neuropathy and numbness, and you can have cognitive impairment. If you use an example of magnesium, if your magnesium is low, you can have spasticity and cramps and spasms. So eating a healthy diet, eating foods and leafy greens and vegetables of different colors is a really good idea to get minerals and vitamins. And taking a multivitamin is a really good idea, just to make sure that you're getting all that stuff and you're not missing it from your diet.
Right, thank you. All right, great for that. All right, next one is Monique is asking, how do you know if you have cramps in your feet or if it's MS or if it's something else?
So you know if you have cramps in your feet, if you suddenly have excruciating pain in your feet and your muscle balls up and it hurts like the dickens. So you know if you have a cramp. Now, whether it's coming from MS or something else, you might not know. And again, I don't want you to play Dr. Google. I want you to remember when the cramp occurred, what triggered it, what made it worse, what made it better, how often it was happening. And I want you to bring all that information to your provider so they can help you sort it out. And they can help you figure out exactly what it is and what's causing it and how to treat it. Because there are lots and lots of treatments for cramps in your feet, including Botox to your feet, including massage, including medicines like baclofen and Xanaflex, including stretching regimens, including physical therapy. Lots that we can do to help.
Great, thank you. All right, next we have Tamina. Hi, Dr. Aaron, thanks for all the info. I've been telling my neuro that whatever weakness I have is getting worse. His answers are it's the consequences of MS. It's just a fatigue. I've been asking about steroids, but he always says it's not good for your bones. And now I have a hard time walking. I don't know what else to do. Your thoughts?
So this can be tough. And you're right that exposure to steroids again and again can weaken bones. But there's other things to ask about. Ask for a stent of physical therapy. Ask for some rehabilitation. If there's a motor fatigue, ask about using Ampura, which is a pill that can help with motor fatigue. If it's a heat sensitivity, same thing, or using a cooling vest. If it's because of spasticity, then maybe we can work on that. Maybe the disease-modifying therapy isn't adequate. I think there's some things that we need to think about. And if ultimately he says, look, there's nothing I can do, I always think it's relevant to say, hey, can I have a second opinion, just to see if there's a different idea, not to leave that doctor, just to bring new ideas into the relationship.
Thank you. All right, next person wants to know if throat soreness or dryness could be caused by MS because she's always having to clear her throat.
So throat soreness or dryness is unlikely to be from MS, but problems with swallowing and sometimes needing to clear your throat is related to that, is something that you can see in MS. And so when someone with MS is having difficulty swallowing, that's very serious because we don't want to put food or saliva down the front tube into our lungs. We want to put it in the back tube into our stomach. And so if you're aspirating and you're putting food particles and liquid particles into your lungs, you have a risk of aspiration pneumonia and sepsis. And so we have to take that very seriously.
Great. What about for those that have developed like a hoarseness every afternoon because they're speaking so much during the day that every single day they just go hoarse.
So I've seen this before. Sometimes it's motor fatigue related, and the medicines like Ampera can help. Sometimes a nap can help because you reset your battery and you kind of recharge, and that can be very valuable. Other times we're not able to make it better, and we literally have to be judicious about using our voice during the morning so we can save some for later in the afternoon. So we have to kind of figure out different ways of gaming it out.
Okay, great. Thank you. Edith wants to know how she can increase memory.
So I listed a couple examples of ways of increasing memory earlier. Let's go back to the idea of doing intellectually challenging tasks. So instead of staring at the boob tube at night, turn it off and read a book and then talk about it. Or jump on an MS chat forum and have a discussion. Or do a crossword puzzle or a Sudoku puzzle. Challenge yourself.
Okay, great. Thank you. Speaking about boobs, Dolores wants to know, getting more and more MS hugs around and under chest and under the breasts. What can you say about that?
I can say it's extremely painful. I can say that it's unfortunately not uncommon. I can say that it's oftentimes misdiagnosed as chest pain or lung discomfort or something like this. And I can say that it's easily treatable. There are medicines for that stabilize cell membranes and can make it better.
Great, thank you. Ron would like to know what your opinion is for HSCT therapy, and that's stem cell therapy for people that don't know.
Yep, hematopoietic stem cell therapy is not a medicine, it's a procedure. And it's been studied in MS for several decades, and it's ongoing. It's not prime time. It should not be done in a tourist environment where you fly to an exotic location and pay $20,000 to $50,000 and they do a stem cell transplant. That is not safe. It should be done in the context of clinical trials today. And I do think that it's becoming really exciting. It's becoming slightly safer. And I think that it will be something that we do as prime time in the next couple of years.
Thank you. All right. There are many people that are writing that, they use a handicap parking plaque or sticker or whatever it's called. And they get out of their car and, they might have fatigue. But people got to bitch and complain to them as they're walking around in the parking lot. Hey, you don't belong parking there. What can a person say?
So there's a couple things you could say. You could say nothing because it's none of their freaking business. You could tell them to mind their own business because you're not under any ethical or cultural obligation to explain yourself. If you wanted to help educate them, because sometimes you want to help out, you could say, I appreciate your comment. I have multiple sclerosis and I have motor problems when I walk too long, and my doctor feels this is necessary so I don't fall and shatter my hip, but thank you for caring. There's a couple different ways that you could approach it. You could say, I know I don't look sick, but you don't look stupid and ill-informed, and yet here we both are. So it really depends on how much you want to engage. I honestly would either say, hey, thank you for bringing that up, but I actually have a disability called multiple sclerosis, or I would just not say anything. And I just want the person who's asking the question to feel confident that you're not doing something wrong, you're doing something smart, and you're not ethically obligated to help them understand.
Okay, great, thank you. Lori is writing an interesting question, which many others have asked things similar. There are so many new DMTs. If the current one is working, is there any benefit to consider something new? But continuing with that, I've heard from many people saying that their medication they feel is working for them. They have not felt any worse, yet their doctor seems to want them to jump onto something new.
So there's an old expression, if it ain't broke, don't fix it. And that's a tricky expression in MS because a lot of MS is invisible. So when you say it ain't broke, you got to be really sure that it ain't broke. So it's not okay just to say no attacks, no new spots. Is there an acceleration of brain volume loss? Because that's not okay. And some drugs control brain volume loss better than others. Are you failing the litmus test of life because you're slowly worsening in a way that doesn't allow you to walk on a soccer field to see your kid play? Or you have to back away from outings? That's not okay. My point here is there's more to it than just, I haven't had an attack. Are you able to keep working? Are you having increasing difficulties in the bedroom or in the boardroom? And so there may be reasons why the neurologist feels that it's not as stable as you might expect. And so one thing you can do is say, why do you want to do that? And they should have an answer. They should say, this drug offers something different than what you're on, which I think will help us in the future, or something like that. Now, if you truly are a super responder to the drug and we can't find any evidence for anything, I think it's a discussion point. I'll give an example. I find some of the low dose interferons to be very, very low efficacy, and I don't like them, and I don't prescribe them. And I have a couple patients that have been on these shots forever, and they're doing amazingly well. They're doing really, really well. They have no cognitive impairment. I've done neuropsych testing. They have no spots. I get MRIs every year. Their exam hasn't changed. I examine them several times a year and do testing. They're not having any deficits. They're working full time. Okay. Do I tell them they have to change? No. I tell them that there are drugs that are better, but I can't prove to them that this drug's not working, and they want to stay on it, and so we stay on it.
Great, thank you. You know how you got angry earlier at something that you had to close your eyes and really repress your feelings? Well, I just got the same because somebody asked me if this is XYZ's program. No, it's not. It's an MS Views and News program, okay? And I don't know why you didn't see that. It's right there, all right? Right up on that screen there, okay? Yeah. It says MS Views and News, and we are the leading MS organization in the United States providing educational programs since the pandemic began, okay? That's all I'm going to say about that. Okay, made me angry now, okay? All right, BK inhibitors. What can you tell us about this? Elizabeth is asking this.
So Elizabeth, BTK does not stand for bind, torture, kill, like the serial murderer a couple decades ago. When I first mentioned to my family BTK, that's what they said. Oh, bind, torture, kill. And I thought, what? No. It's Bertine tyrosine kinase inhibition, all right? So BTK inhibitors are these small molecules, they're pills, and they've been studied and approved for certain types of cancers. And what we found is it looks like they're freaking amazing to treat MS. BTK inhibitors are very well tolerated, and they don't increase risk of infection, which is pretty awesome during a global viral pandemic. I'm currently involved in several BTK inhibitor trials at my center, at the Boster Center, where we're testing several BTK molecules, both in relapsing MS and primary progressive MS. Now, what they do is weird but cool. So we know that killing B cells is a very effective way of treating MS. And so there's lots of drugs now that kill B cells, like Rituxan and Ocrevus and Kesimpta and Limtrada and Mavenclad. They all have impacts on B cells, but they all do it by murder. And it turns out that we can use a BTK molecule to block B cell communication. So you don't kill the B cell, you just can't hear it. So you don't know what it's saying. And that accomplishes a similar goal without killing it, which is pretty cool. Moreover, BTK molecules can impact a cell found in the brain called the microglia, which is part of the innate immune system. And we've never before been able to alter the innate immune system. And so I'm very, very excited about BTK inhibitors and what they may mean in MS. So thanks for asking the question.
Great, thank you. Thank you for that. So, you know, I put out on social media recently that lions and tigers and bears oh my, and that's how I was describing this program. And when you were just giving your answer to that question, I said, wow, lions and tigers and bears oh my, yeah. B cells, T cells, MABs oh my. And so many people have difficulty understanding what the heck is being spoken about. So you quickly describe the difference between B cells, T cells, and monoclonal antibodies.
Yes. So it's a bit of an alphabet soup, isn't it? So we're talking about the immune system. The immune system has two parts, the innate immune system and the adaptive immune system, right? And the adaptive immune system has two parts, the T cells and the B cells. And those are different populations of cells. T cells grow up in the thymus, T for thymus. B cells grow up in the bone marrow, B for bone marrow. And both T cells and B cells are involved in MS pathology. In other words, your T and B cells made an error in judgment and they attack parts of you. Now, monoclonal antibodies is really a medicine created in a laboratory where a scientist created an antibody, an artificial antibody that impacts your MS.
Thank you. All right. Next, Joe is asking, a different Joe is asking, I tried it's my brain, etc. No go, not interested at all. 3 neuros have refused. Also, they are not prepared to prescribe a DMT because I'm SPMS. Anything you can say?
Yes. If you hired a plumber who insulted your wife and told her that the sink she picked out was ugly, you'd probably get a different plumber. And if the second plumber refused to put the sink in where your wife asked him to, you'd get a third plumber. And so doctors are like plumbers. And if you don't like their partnership and their therapeutic alliance is not there, go see a fourth person.
Okay, thank you. Mark would like to know, what do you think, and I never heard of this, about JOCOVRI, JOCOVRI, as opposed to Ampera?
He should win an award for stumping us live online, because I don't know what that is. And that doesn't happen very often in the MS space, but I'm not sure what that medicine is. And so I'm going to have to look it up. That'll be my homework. Now, I want to give a 3-minute warning. We're going to have to wrap up soon, and I'm hoping we can hit another question or two before that time.
3 minutes. Oh my gosh, we're in trouble. Okay. What kind of question did you want to hear?
Something fantastic.
Something fantastic. Why don't you make it up?
So what's a good question that we could ask? Should we get a COVID vaccine? That's a good question. And the answer is that you should get a COVID vaccine. And if you're on a B-cell depleter, you should still get a COVID vaccine. And if you're on Gilenya, you should still get a COVID vaccine. And the world is scary. This global viral pandemic is not over. It's impacted every aspect of our lives. But there are 2 things that help us stay safe. Number 1 is getting vaccinated. And when you get vaccinated, it stimulates the T cells and the B cells to fight against COVID. And so even if your B cells are suppressed for some reason, it's still a good idea. The second thing is we can wear a mask. I don't have MS, I'm not immunosuppressed, and I am fully vaccinated, and I wear a mask when I'm outside my house because it's smart. And I wear a mask when I'm in my clinic because it's smart and because I don't want to risk transmission. If you look at what's happening in the United States right now, parts of the world where they're vaccinated, the death rates are going down. Parts of the world where they're not vaccinated, the death rates from Delta variants are going up. And so what's a good question? Should I get vaccinated? And the answer is yes.
Okay, what about for those that have been vaccinated and all these talk about the boosters? Should people get vaccinated? And what about those that are on B-cell depleters?
So my opinion is that boosters make a lot of sense for people that are immunosuppressed. And it's my belief that very soon that is going to be a formal recommendation. And if you are on a B-cell depleter, all the more reason to get a booster, because we know that some people on B-cell depleters have trouble mounting a response, but the more antigen you show them, the more likely that they'll be able to mount a response. And so I think a booster is in the cards in the near term.
Okay, people are asking me about you, all right? They want to know how they can contact you. Can they use you for a second opinion? How they make a telehealth call with you? We are going to be discussing this on Tuesday. I would like for Dr. Boster to answer this really brief, and I would rather answer it in more detail on Tuesday.
Fair. Thank you for inquiring. You can find us online at bosterms.com, BOSTERMS.com.
Great. Thank you for that. All right. I don't want to keep things waiting. I do want to say that we did have over 100 people online today, and I want to thank everybody that was online today. Thank you for being here. Thank you for trusting this program. I do hope that you sign in, go to our website, go to the center column of the website where the list of all of August's programs are there. Okay, and you get signed up. We have Pilates, yoga, physical therapy happening every Monday. It's called Moving Mondays for MS, all right? And so we have that there. Also, there are tremendous amounts of information that you can find by going to our YouTube channel where Dr. Boster even mentioned there are hundreds, if not thousands right now of videos there that benefit everybody affected by MS. There are lots of questions that have not been answered or even asked, okay? They are on the YouTube channel. If you go and you use the search box on there and you type in just, a few keywords, click enter, it's going to find it in one of our programs that we've already had, all right? And if you want to know more, just come back on Tuesday and ask Dr. Boster the questions at that time on telehealth. Come in and be part of our program on Wednesday, which is aging with multiple sclerosis. And then the following week, On the 18th, there is a men's program, men's issues with multiple sclerosis. I couldn't even say that right. I'm getting hoarse. All right. And on that program, it will be Tyler Campbell, Damian Washington, and myself. We will be speaking very open and honestly with anybody that's listening to this program. And our talks will be about depression, about sexual issues, about other health issues, about whatever people want to throw at us and get our opinions as well. All right. So, Dr. Boster, again, thank you for being here with us today. And again, thank you to everybody for being on here. And again, I want to thank Genentech for helping to sponsor today's program. This is an MS Views and News program. And I want to say goodbye and thank you to everybody. Have a great day.